So again, a very good morning. We have to we are actually entering into afternoon, and mainly what we focused in this particular crash course is about the physiology. So few of the concepts already sir has taught, and we have learned from him. But that will keep repeating, and with the blessings from sir, because whatever knowledge I'm going to share with is all because of I got such a best mentor in the world, and that is why I'm able to share all the knowledge with you. So this is about ovarian reserve testing, and particularly I'm going to talk much about AMH and what is the maze of this AMH in poor ovarian reserve. So we are going to talk about all these topics step by step. What exactly we want to focus upon is when we talk about ovarian reserve test, one of the important ovarian reserve tests if you want to have is age, which is non-modifiable, and according to the age it's a qualitative marker, and many criteria when we talk about the patient. First criteria what we have to take into consideration is about the age when we talk about AMH, when we talk about the ovarian reserve testing, and other things about AMH, AFC, FSH, inhibin B, and other things we already know of. Now, we should have a nomogram in particular of AMH related to age. How as the age advances, and what is the age group and what is normal AMH for that age group. But such nomogram sadly doesn't exist because every population or ethnicity is different, and everyone be having different age of menopause. Let's say in India 12% of the women are attending menopause before 40 years of age. That is not there in Western countries. So that can have a different altogether levels. So sadly we don't have a normogram age related AMH. But Richard Fleming has in 2015 has done very beautiful study that we should know what is the trajectory of AMH since the time the girl has born till the time she attends her menopause. So this follicular recruitment means by the time a girl attends her puberty, her first menses, 70% of the follicle pool has already depleted. Now, once, in overall whole her lifetime, she is going to have ovulation only 300 to 400 times, and all other follicles are having a fate nothing but to go for atresia. So, once this follicular recruitment peaks at menarche, and after that also the primordial pool is going to convert it into antral follicle, and as we learn that whatever AMH we get, it is from the preantral and antral follicle. So initially when she is about to have puberty, that time her whole ovarian reserve is not still expressed, so we can't label on that basis whether she is having low ovarian reserve, normal ovarian reserve, or high AMH. So we have a very limited information between age group of 14 to 35 years, and that is why it's very difficult to advise. If you look at the graph, this AMH, it is in the red line, and this is about the continuous depletion of the follicles. So if you look, since the time birth, the AMH is still rising, and it is maximum at the age of 25 years. So imagine the girl has attended her puberty at the age of 12 to 13 years. That time maybe her AMH will be still low because the primordial pool has not expressed. After that also there is a continuous recruitment. So AMH peak will be at the age of around 20 to 25 years. So many times what happens, why it is important to know about this, that there could be a girl who has attended either late menarche, or since the time her periods from her first menarche, she is having irregular cycles, and now they are consulting you, and then by default you are asking them to do AMH, and AMH come 1.2. Then you tend to say that you are at the age of 18 years only, you are having AMH of 1.2, and this is very, very low. Now you have to think about early marriage, and we will counsel too many things to parents, and we are making them unnecessarily anxious because we are not knowing about this physiology. This is a trajectory what we are discussing with them, because AMH, that primordial pool, has still not got expressed, and now till the time she is going into 20 to 25 years of age, the AMH is going to increase. So that is why for adolescent girl who are coming with irregular menses, though they are having low AMH, that doesn't mean they are poor ovarian reserve patients and now they are going to have early menopause. Please don't counsel. You just have to tell the irregularity. Then you have to take into consideration another factors like FSH and LH. You have to look at the FSH level. If the FSH level is still normal, means obviously she is not going to have that depleted ovarian reserve very early, and you can still wait and counsel that girl, nothing to worry, and you just have to regularize the cycle depending on whether this irregularity is because of her sudden weight gain or any other things that we have to point out. So this AMH will continuously rise, and After that, the AMH is going to fall, and we know that after menopause it's going to be very low, and that is why the ovarian reserve will be depleted. But what is important again is this continuous depletion of the follicles, and these non-growing follicles will be continuously having atresia. That is why we are not having that at what cutoff we should say that this girl may have very low AMH and have to go for early planning for her reproductive or fertility. Now this is again a repetition that AMH will be secreted by secondary small antral follicle. 2 to 6 are small antral follicle, they are definitely secreting AMH, but between 7 to 9 we may have some like few follicles who are secreting or contributing to AMH, and few follicles are already destined to go for atresia. This was again that initial phase is FSH regulated, it is not FSH independent, because some amount of FSH will be needed from the primordial follicle to go to secondary follicle, and that is why it is FSH regulated rather than gonadotropin independent. And as the follicle is growing, we should know that the follicle grows in very low oxygen environment. That is why we have CO2 incubator, we don't have oxygen incubator, because whenever the follicle is growing it should have a very low CO2, because pyruvate is one of the substrate, and CO2 incubator are must, because we maintain that level, because it's an anaerobic mechanism how the development is going to happen. Now when we talk about as we have already discussed about first is adrenarche and then is menarche. Why it is so? Again, when we have adrenarche, when there are certain number of androgens which is important for the follicles to have as a substrate. Now this androgen inside the ovary is going to there are follicles, and now these follicles are getting exposed to the androgens because of the adrenarche. All the follicles will be having FSH and LH receptor. So there will be an interplay of this androgen with this FSH and AMH interactions will be there in the pre-antral follicular development. Now when androgens are there, and these androgens are going to enhance more FSH receptor on these primordial follicles. These primordial follicles will be still having a thin layer of at least 1 or 2 layers of thin granulosa cell layer, and now this granulosa cell layer will be having more FSH receptor expression because of the androgens. Now this small amount of FSH along with androgen, and there are certain growth factors at that time of puberty which is important, like we read about BMP9, IGF-1. This factor at that particular time of puberty, this will be having interplay and more FSH receptor will be there. Now because of that, more amount of FSH receptor will be there, and now there will be a role of LH receptor. With this granular cell proliferation, there will be some amount of E2 which is being generated, and as E2 is mitogenic hormone, this E2 is going to increase the AMH expression in the follicle. So now this follicle has pushed into a secondary antral follicle and secondary follicle, and it is going to into pre-antral follicle. The follicle which will be having the FSH receptor acquisition first will be having LH receptor, and now it is started expressing AMH receptor. This follicle now is going to have a antral pool. So AMH will act as a gatekeeper. If the AMH is very, very high, that is not going to allow the FSH action to happen. So this increase in the AMH expression means there are multiple follicles who are not secreting AMH, but unless and until there is a hypothalamus pituitary ovarian axis interplay and the FSH is going to come into picture and having more the LH receptor which is going to be predominant on that follicle, till that follicle that getting selected, other follicles are going to have a low FSH threshold. That is why on day 2 of the cycle we see 14-15 follicle, only one of them is going to grow. But these other follicles are also contributing to AMH because these are follicles which are pre-antral and antral follicles. But why they are not getting dominant? Because they don't have LH receptor, and AMH is acting a gatekeeper from them, and it is acting as a threshold, not allowing the follicle to grow. So these 2 to 8 millimeter follicles are going to express AMH. Now once we have the follicle which is going into pre-antral or antral stage, now the follicle from that stage is going to go into a pre-ovulatory phase, and this is under the interaction of FSH AMH estradiol interaction in the follicle development itself. Now this is a gonadotropin dependent therapy. Now this girl has attended menarche. There is a GnRH pulse frequency which is regular, and there is FSH LH which is going to come in like pulse every now and then. What is going to happen that the follicle who has aromatase expression and estradiol represses the AMH expression. So now what we discussed in first slide, it is gonadotropin regulated, where now we have follicles which are expressing AMH. Now at this particular time, when there is FSH into the action and the LH receptor which is dominant in that follicle, there are more amount of granular cell which is going to generate under the action of FSH and under the action of estradiol. Now because of the high amount of estradiol, the aromatase expression in that particular follicle is going to come down. Now this E2 will be having follicle transformation and increase FSH receptor expression, and which will again improve more amount of LH receptor on that particular follicle. So you have a follicle which is now initially was expressing AMH, but there is an interaction of FSH on the follicle. Now the FSH is acting on the follicle where there is a interplay of estradiol. The aromatase expression of the follicle is going to come down, and because of that this follicle will acquire LH receptor first. Now this LH receptor, and there is more amount of E2 being generated with the granular cells proliferation. Now this follicle is going to lose AMH expression. So follicle who will be having who will lose the AMH expression first, who will acquire the LH receptor first and will be regulated by more amount of E2 is the follicle which is going to get dominant, and that is why increase in E2 will have growth of the follicle, and there is a cyclical recruitment follicle. So when the follicle goes beyond 8 millimeter, the AMH expression goes down, and now this follicle is going to become dominant. So why particular this follicle become dominant? This has these many theories. The first one is regulated theory and another one is gonadotropin dependent theory. So AMH is a modulator of follicular growth and it regulates the FSH threshold. So AMH represents the functional ovarian reserve in younger age, and because the primordial pool is not getting expressed into antral follicle, but in younger age the primordial follicles are not secreting AMH. That is why we are not looking at the true AMH expression in the younger girl. But oppositely, let's say at the age of 38 years, the primordial pool has already declined. So 80% of the primordial pool has already declined. So now you are whatever you looking at is a true ovarian reserve. So whatever you are looking at the AFC, that will coordinate with AMH in older age, but in a young girl it is a functional ovarian reserve. So let me focus mainly about the AMH, because the first is what we advise in our clinical practice to see the fertility is about AMH. But sadly, we should understand that AMH is not a fertility test. It is just a quantitative marker which is going to tell us at this age what ovarian reserve she has. So in female, the AMH secretion start at the age of 36 weeks of her list and peak at the age of 25 years, and this inhibit primordial follicle recruitment. Why AMH is high in PCOD? The AMH is now, there are preantral follicle which are secreting more amount of AMH, but they are unovulatory because the certain amount of FSH which is coming from the pituitary, that FSH threshold of these follicles is very, very high. So this AMH is acting as a gatekeeper. High AMH is expressed, and that is why the follicle is having very high FSH threshold. So unless and until you are giving ovulation induction agents to them or gonadotropins to them, the FSH threshold is not going to overcome, and that is why PCOS people are unovulatory. So one of the theory is why AMH is a inhibitor is mainly because it raises the FSH threshold. Factors affecting the primordial pool. So when sir was describing about how if the mother is having PCOS, now she is having very high amount of androgen and very high amount of AMH. So what happens when she is carrying a female baby? This AMH, when it is going to have a circulation through the placenta, this AMH blocks the aromatase activity in the placenta. So because of that, what is going to happen? Whatever the amount of testosterone LH is going to go from the mother through the placenta is because of the high AMH, it is not going to convert into estradiol. So at this level, a very high androgen exposure is going to be there from the placenta through the female fetus, and that particular time the female baby is going to have more amount of androgen exposure. This will have a high AMH. So as sir was mentioning, if somebody is going to born with 4 million follicle, this particular girl will be having 8 million follicle at the time of birth itself. And this is because of this theory that high androgen exposure in the uterus will be having high androgen inside the female fetus also. Now it is not only the androgen exposure from the PCOS, but there are many multiple factors. Like if you see in your clinical practice also, there could be a sibling where, like, recently only last year we have one patient that at the age of 27 years only she had premature ovarian insufficiency, but her mother is still having menses at the age of 46 years, and her sister sibling, she is at the age of 32 years, she already have one kid, but this poor girl is suffering with premature ovarian insufficiency. And it's very, then everybody wants to ask the same question, they will ask the same question to you, doctor, in our family nobody has, but then why specifically I got this less ovarian reserve? One of the factor could be FMR gene mutation, but very very less likely if the in family it is not running. But the other factor is environmental factors which can contribute to have low AMH in this particular, and this will be because of the unhealthy environment. So nutrition of a lady at the time of her ANC is very very important. So good amount of nutrition in the form of proteins, in the form of iron and calcium is very important. And diet in ANC period, if there is an inadequate protein intake, that will lead to diminished ovarian reserve in the female baby and rapid decline of ovarian telomere length. And chronic inflammatory state like IUGR, if there is a female fetus and at the age of she is having IUGR which is of severity of grade 3 and 4, in that patient there will be a reduction in the follicles in primordial follicular pool through the premature cell apoptosis. So it is not only hampering at inside the uterus, but it is harming the reproductive health also. So that is why siblings can have different ovarian reserve, because of this theory that it could be nutritionally or environmentally challenging for that particular time. So when we we'll take a scenarios like high AMH and low AMH. When we talk about high AMH and PCOS, high AMH is secreted by individual follicle, and increased pool of AMH will be having a secreting follicle. So this is a slide, if you hear lecture from Dr. Anil Gudi sir, he will be always having this slide about describing the PCOS and how we can divide a good PCOS and bad PCOS. So if we look at the ovarian volume, as we again and again saying the same thing, that AMH is having inhibitory role. Higher is the AMH, higher is the FSH threshold, higher is the PCOD resistance. So what happens, they will be having higher AMH and higher FSH threshold, high volume and higher threshold. And if you see a lady with PCOS who are having a resistance PCOS, she will be having very very small follicles. So they will be having follicles which are less than 2 millimeters and very thick stroma. So then you are looking at a resistance PCOS patient. So if you have somebody who is having follicles which are very small, these are more difficult to stimulate. But if you have a PCOS where all follicles are more than 4 AMH, 4 millimeter, then it gives you a hint that these follicles will be having least AMH expression, because they have crossed whatever the theory which we have explained just now. And that is why they are more responsive. If you give letrozole, they will be having 2 follicles. So they are good responders. So this group were very good responder in PCOS, because we get PCOS with many things. There are good responders, there are average responder, and there are patients who are having a very low response with ovulation induction agent. So if you have lower the AMH, means it's a good PCOS, larger the follicle, lower the threshold, and less thicker element, lower the threshold. So in these particular patients, there will be less stroma, and they will be having follicles which are dispersed in the ovary in a diffuse way. So when we look at the AMH and volume of AFC, why need to understand that why there is a bad PCOS and why it's a good PCOS? A good PCOS, as I mentioned, that letrozole forming 2 follicles, or she is responding to ovulation induction agent. But if you have a lady who is given history that unless and until she started, she takes a withdrawal, she don't get menses. So with history, how you can differentiate a bad PCOS and good PCOS? Bad PCOS will be having a history that unless with medicine she is not getting withdrawal. And maybe you will be having a very thin girl that since her menarche, she is having irregular cycles. She will be having a BMI of 18 or below that, and still she is having anovulatory since her first menarche. Again, she is a very bad PCOS. So high BMI, high androgen definitely will be having a bad PCOS. But looking at the ovary, you get much idea. And the best way of having to judge whether it's a resistance ovary or not, a good PCOS, is to stimulate them with ovulation induction agent, and you will come to know the response. Because in our clinical practice, you may have a lady of 10 AMH and she will respond to letrozole. But you may have a lady with 5.6 AMH, but still she is not responding to letrozole. So unless until you give ovulation induction to them, you won't come to know how they are responding. And what we are scared of both the things, very low response and very high response. So when we are giving letrozole, she is not responding, then whether adding clomiphene citrate, whether she will be having multiple response, or if that is also not responding, giving gonadotropins with smaller dose, whether she will having larger response, again that will be having on this particular slide. If you have a very increased volume or AMH of more than 7, maybe she is not responding to ovulation induction agent, and you may have to go for gonadotropin, but she may have very massive response, because you are giving her 75 IU, it is not responding, and suddenly you increase to 150. Now suddenly there is exponential growth of the follicles, because now all the follicles have crossed the threshold, and that is why she is having massive response. If a normal respond, then even your simple ovulation induction agent or 2 gonadotropin injections will have better response in this particular group. So PCOS very difficult to stimulate, if you are seeing AFC which is more than 420 in each ovary, AMH beyond 8.4, very high androgen level, very small follicles which are less than 4 millimeter, step up often fails, and immature oocyte. And what is the main fear is OHSS. If you are going to give this continuously, she had taken 10 gonadotropins, but now she has massive response. You have to again ask them to cancel the cycle and go ahead with the next. So when we plot out AMH versus ovarian response, it is a bell-shaped curve, where at low AMH also you have low response, and at high AMH also you have very low response, because the FSH threshold at this particular time is very high, and in this level there is low AMH, means low follicle number, and FSH is going high because of the ovarian insufficiency. So at these both extremes we see low response. Now what is our things to discuss, and what are the maximum literature published, is mainly when we have a normal ovarian reserve and we suffer either low response or high response. So this I already discussed. When we talk about PCOS, and we have certain criteria, how a good PCOS will have a picture on the ultrasound, and how a bad PCOS will have. So rosary pattern, if you see a necklace pattern, there is a thick stroma in between, and all the follicles are arranged in a necklace fashion. So this is a very difficult PCOS, because it's a high androgen, they have high LH, high AMH, and this will be a typical girl who is having irregular cycles since her first menarche. She is a very lean thin PCOS, and this could be because of genetic factor. And this is a rosary pattern where on the ultrasound we can gaze. And why it is important, that we need to understand PCOS doesn't mean weight loss, in whom we should advise weight loss. So this will guide us that which patient will respond to weight loss and which patient we have to go for directly treatment. If you have a diffuse pattern where all the follicles are dispersed in the ovary and there is no high stroma, they may have high androgen, but their FSH-LH ratio will be normal. They may have high BMI. So initially the periods were regular. Now because of induced obesity, they are having irregular cycles. The lifestyle basis could be a problem, and in this patient the reason could be more insulin resistance. So now we know that if a lady is having a diffuse pattern, she is a very good PCOS, and it is lifestyle induced factor, then ask that lady to go for weight loss along with metformin and BMI correction. So this diffuse pattern PCO morphology, it will work in that. But a lean thin PCOS, what you are going to achieve by asking them to go for weight loss, or since the beginning she is having irregular cycles and she is a difficult PCOS, she requires a very good FSH stimulation rather than working on weight loss. Now when we look at the pathophysiology of PCOS, the normal ovary LH elicits E2 and progesterone only from the follicles which are beyond 13 millimeter, because sir has shown you that figure that initially there are 80% of FSH receptor and only 20%, but as the follicle is become dominant, you have more amount of LH receptor and less FSH receptor. But what happens in PCOS, at 2 to 4 millimeter only, they have inappropriate response to LH. So what we are fearing nowadays is a poor ovarian response in PCOS, because we think that we should give a lesser dose because we don't want to have OHSS, and we know that very certain that even with 150 IU of FSH, she is going to respond. But if you are not giving adequate dose, you may face poor response, and this is because of the mechanism which I am discussing now. So what happens in normal follicular development, once the granular cells, this is in a normal patient, once we have follicle which is of 5 millimeter, they have only FSH receptor. Now when the follicle is getting selected, it is now 10 millimeter, Now at this point, the follicle is going to have FSH and LH receptor. After this follicle, there will be 2 cell division and the follicle is going to be pre-ovulatory. So this is what happens in normal ovulatory cycle. But in anovulatory PCOS, even at 5 millimeter, this follicle is having FSH, LH and insulin receptor. Now if you imagine this follicle is now undergoing 2 cell division, it will go till 8 millimeter. But with this 8 millimeter, now it is having very high LH receptor. It increases cyclic differentiation in the follicle, and instead of this follicle going towards becoming dominant follicle, it is now an atretic follicle. So many times in PCOS, we see the follicles are growing, but actually we don't get anything when we have a oocyte retrieval. This is mainly because of this theory that in anovulatory PCOS, granular cells are responsive to LH at 4 millimeter size. If cells can undergo 2 divisions, expected follicle will reach to 8 to 10 millimeter, will be having high cyclic AMP differentiation, and instead of giving a COC complex, it will be having a path towards atresia, and that is why you see 30 or 40 follicles in PCOS at the time of pickup, but you may retrieve 20 because other follicles fate is nothing but to go for atresia with this particular theory. Now there is one more theory in PCOS, that there could be a stockpiling of the follicle, because we always again and again said that AMH will act as a gatekeeper. So from primordial follicle to reach into antral follicle, AMH is again having a act like a gatekeeper. If certain follicle number is actually overcoming that FSH threshold and they are now going to pre-antral follicle, this AMH with the theory which we have learned now, even at 5 millimeter will be having high LH receptor. They will go to 6 to 8 millimeter and become atretic, but they are still in the ovary, and again this AMH is only not allowing this follicle to go for further development. Now this AMH will be having anti-apoptotic follicle on the follicle which is going beyond 8 millimeter. So you see lot of herd. You will see in PCOS ovary there could be follicles of 10 millimeter and beyond, could be of 8 millimeter, and if you start stimulating at any particular time, because of this stockpiling of the follicles, you may not get adequate response. And there are in severe PCOS also, like how when we categorize PCOS, as we discussed that we have certain criteria about their menstrual cycle, whether they are getting withdrawal, whether they are inducing with ovulation agents, and about rosary pattern, about diffuse pattern. So again in severe PCOS also we have different criteria. So the very difficult PCOS is lean PCOS, because you can't ask them to have weight loss. They are having a very high androgen level, very difficult to stimulate with ovulation induction agent, and you may have to take them for IVF only. But in severe PCOS also, like when we categorize, one is about this lean PCOS, thin and tall girl with high AMH. Now this PCOS lady, she has attended her menarche late compared to her colleagues, like she has attended her menarche at the age of 13 years, or delayed menarche is there, and she has now maybe could be a nutritionally problem, or could be because of her genetic hit which we just discussed, and she now had a lean PCOS. We have PCOS, what we just discovered, that what is bad in PCOS is not high androgen level. What is bad in PCOS is high insulin resistance. So a lady who is having high insulin resistance, increase LH, and along with that if she is having high androgen levels and BMI, she is again a resistance PCOS. Then there are PCOS girls who are having hypogonadotropic hypogonadism. So whenever you are asking them to get the blood test when for a fertility evaluation, it is must to have baseline FSH and H level, because hypogonadotropic hypogonadism people can have different scenario. They can present with low AMH, they can present with normal AMH, they can also present with PCOS. So there could be a category of hypo PCOS, and there could be PCOS group who is having FSH receptor polymorphism. So you may have PCOS patient whose FSH level could be more than 8, though they are having high LH, but FSH level is more than 8, which will again raise your antenna that even this patient will be having a normal BMI. Instead of 300 units of gonadotropin dose, she may require 450, because this FSH is little at the higher threshold, and that can give a hint that this lady may not respond to the regular dose of gonadotropins to overcome the FSH threshold for these particular follicles. Now when we talk about this, I'm not doing now. Now when we talk about in PCOS, we give always metformin, as sir was suggesting. The metformin work very beautifully in adolescent PCOS. So whenever you have a girl who is coming to you with irregular cycle, not yet married, so instead of advising them only to go for OC pills, it's always better to go for metformin, because there will be lean PCOS who will come with these symptoms, and that will work very better in that. And along with metformin, what we can give is vitamin D, because insulin resistance and vitamin D goes hand in hand. There are 70% of the PCOS lady can have this vitamin D deficiency, and that can aggravate their insulin resistance. So vitamin D supplementation at this particular age is very, very important. Now, apart from this, whenever we have adolescent PCOS, many times we tend to give them OC pills. That should not be given, because OC pills is only cosmetic treatment, and many times we just advise them to go for weight loss, but nobody focus on regularization of cycle of the PCOS girl. So if you give them diet, metformin and exercise, but you are not regularizing the cycle, she won't be able to lose her weight. So it's very important to regularize her cycle, and along with that you have to give the other therapies. With regulation of cycle, you have two choices: either you can give pragmatic progesterone. So ask that girl to take progesterone pills after 35 days every time. Don't wait for longer time, because the more she is waiting for her period, more amount of insulin resistance is going to accumulate, more amount of androgens are going to accumulate, and that is going to make her PCOS very difficult. So she has to take pragmatic progesterone every 35 days to get her withdrawal. But nowadays what we are doing is we are taking their consent and we are giving them letrozole, because we are making them understand that we are treating your basic physiology, because otherwise your other colleagues are now having ovulation every month. That's why they are having regular cycles. This letrozole is specifically is a fertility drug, but we are giving to treat your physiology. You just have to take a consent, because we are not regularly giving this as a fertility medicine. And believe me, there are so many girls where we have put them on letrozole. They are getting regular cycles. You don't need to monitor. Once you're giving 5 days of letrozole, she is getting her regular cycle. You will see that she is able to lose weight. Her androgens levels are coming down, because her pimples and acne are going to go down. She is able to have a better structure. Hirsutism also getting improved. So rather than giving OC pills, which is just a cosmetic treatment, and that may hamper her figure also, it's better to give letrozole in such girls after giving consent. Then vitamin D supplementation. So vitamin D is a very nice hormone. Everybody anyways should take that, but it has both it's a very labile hormone, where we have to where we have to give it for patients who are having low ovarian reserve also, and patients who are having PCOD also. So Moradi et al., when they had done meta-analysis with vitamin D, AMH meta-analysis was been done in 2020. He's found that vitamin D supplementation decrease AMH in anovulatory PCOS. That is why in PCOS there is a vitamin D role. But it also important in patient with poor ovarian reserve patient, because it also increases AMH in ovulatory non-PCOS. So vitamin D may increase AMH. Vitamin D prevents granular cell apoptosis. So in our clinical practice, it will go to in our prescription, even if it is low response or low ovarian reserve patient or a PCOS lady. So 3 lakh units of vitamin D for 2 months, or you can just simply take 60,000 IU every week for 8 doses, that will suffice the need. So vitamin D supplementation, when they had done that, there is after replacement of vitamin D, they saw that there is increase in the AMH level, and that will in patients who are having low ovarian reserve patients, they have found that if you give vitamin D continuously, that will maintain their AMH also for longer. So decline of AMH also will be prevented, which is going to be otherwise faster in this particular patient. And I have seen that there is increase in the AFC in patients who are having low diminished ovarian reserve. Now low AMH could be premature ovarian insufficiency or premature ovarian failure. Either, as I discussed about, it could be a genetic predisposition, or it is only because of the advanced maternal age. But we can have a scenario where there could be a AMH variation. So AMH does vary throughout the cycle also, but that is not statistically clinically significant. That's why we can do AMH at any day of menstrual cycle. So 20.8% variation in AMH seen in younger high AMH population due to variation of AFC, because not the same follicle herd is going to have in the every cycle. So if sometimes even patients are so anxious, they will do AMH level every 2 months, and they will tell ki last time it was 0.2, now it is increased, it is 0.4. But you have to tell them that it is in the same range, it is whatever the pool you are going to express, accordingly that the AMH expression will change, but it is still going to be in the lower range if you have low AMH since beginning. Now, long agonist expression, long agonist suppression. If you give agonist injection like leupride, either 3.75, we generally don't use 11.25 at all. But if you give 3.75, what is going to happen? That initially it's going to have a flare effect. But later on, because the hypothalamus pituitary ovarian axis is completely suppressed, you will be having a false decline of AMH. So never do your AMH level if the lady has received agonist injection in her last month. You have to get her one cycle and then do the AMH level, because this agonist injection is going to suppress that primordial pre-expression into antral follicle, and you may look at low AMH, which is not the correct value. OC pills, if you are giving it continuously for longer time, you are giving it for 3 months, it is not going to decline the AMH level, but you are giving it continuously, that too, if you are not giving a break in between, there will be a falsely low level of AMH, because hypothalamus pituitary ovarian axis is again suppressed, not allowing this primordial pool to get expressed into a preantral or antral follicle. As like initially only I discussed that AMH is not a fertility test, and this was they have these 2 studies which we have read, which talks about the first study was done by Hagen et al., which in 186 Danish women. The mean age what they have taken into consideration is 26 years. Pregnancy in 6 menstrual cycle, no difference when the AMH was between 1.4 to 5.6. So AMH does not correlate with your probability of getting her pregnancy. It's not a fertility test. Again, they have done a study, which is a eager study, which is a dose finding study of aspirin. When this patient conceived, they have looked at their AMH value, and they have seen that fecundity odds ratio 1.04, and there is no significant difference with AMH less than 1 nanogram with more than 3.5 nanogram. So who won't get pregnancy? They may be PCOS, because with very high AMH they are not ovulatory and we must treat them. But if you have a lady who is at the age of 27 years with 0.5 AMH, she is having a regular ovulatory cycle, you have monitored her one cycle where she is giving a history of 28 to 30 days cycle, her FSH level and LH level on the day 2 is normal, means you can ask her that she has a very good chance of spontaneous pregnancy. She may try for a year or 2 with this ovarian reserve, and there is not going to be a faster decline because your FSH is normal. But same lady at the age of 38 years having 0.5 AMH, FSH which is going beyond 10, then maybe we have to counsel that girl that though you are having regular cycles, but typically she will be having short cycles of 20 to 25 days, because the follicular length is very short, and within 8 or 9 days only she is having ovulation, and 22 or 25 days only she is having her cycles. So this is hinting towards a faster decline of AMH, and for this patient we have to counsel them that you may have to go for intervention as soon as possible. So again we can have 3 scenarios where they are just trying for pregnancy, got the AMH done, and then they had come for consultation, but they are hardly trying for 6 months. Now don't sensitize that girl that you have 0.6 AMH and you have to immediately go for IVF. That is what we want to give a message. Let's say if and then to decrease her anxiety, just tell her that your cycles are 20 to 30 days, will confirm ovulation. In next cycle we do FSH level also. That will give us trajectory whether you will going to have a drastic fall of AMH. So you can plan a pregnancy without thinking that, because it's not a fertility test. That is one scenario. You may have a girl who is at the age of 25 years, because she is having wellness package from her office, she has got the AMH test done. And now your AMH is 0.9, she is not married, she is just 26, 27 years age. And she read on Google and she comes to you and she is saying, doctor, this is what I read, my AMH is very, very low. But now I'm at the peak of my career, I'm not even married, I'm not thinking about my pregnancy and other things. Now this girl you can take for elective egg freezing. Okay, because you don't know, she is only herself is telling that she is not planning now, maybe after 5 years down the line she may get married, or 5 years later she wants to plan a pregnancy. We really don't know what is the trajectory of AMH fall in her that case. So in those patients then we can ask to go for elective freezing. Now in third scenario, you have a lady who is having, even at the age of 27 years, 0.5 AMH but FSH of 12. Now this lady, you can tell her your cycles are 28 days, but your FSH is going high. That is given an idea that it could be qualitatively having difficulties. So you just try for over next 6 months. If you don't get, then it's better to intervene in a better way. If she is having advanced age, definitely no. We have to think in that way. And as sir, you are asking about those patients who are having low AMH, and this patient will be having a high FSH threshold. That is why in this patient you will see many of the atretic follicles, and they will be having a very faster follicular growth because of gonadotropin serotonin deficiency, and the oocyte competence in these particular patients can be low. So we are not saying that it depends on which situation is in front of you, and then we have to counsel in those patients likewise. So AMH is a quantitative marker and FSH and age is a qualitative marker. So about AMH and AFC discordance. So many times we have a scenario that the lady is having AMH of let's say 3, but will be having very low AFC on the sonography, and this is not coordinating. So why they will be having AMH and AFC discordance? So look at these two examples. Both in both the scenario in the ovary we are able to see AFC which is 8. But if you see over here, all the follicles are having of less than 8 millimeter. So these follicles are actually expressing the AMH. Again, went back to our main physiology that between 2 to 8 mm, these are the follicles which are actually expressing AMH, but above 7 millimeter, there could be a follicle which is going towards atresia. So in second scenario, these follicles which are around 8 to 9 millimeter, now the number is again 8, but this could be a patient who is already stimulated, means let's say you are having a second, the lady is coming to you for second opinion where she is stimulated by another consultant, and she had very less oocyte yield, and she has come to you, doctor, doctor is saying that I didn't get good oocytes or didn't form the embryo. Now when you look at her sonography, you are seeing that there are 10 follicles. Then you may promptly say her out that no, you have a very good AMH, this would have been very less likely. No, whatever the follicles you are seeing that has been stimulated in the last cycle, they are now actually going towards atresia, and whatever only these 3 follicles may be contributing to AMH. That is why though AFC is same, this lady is having AMH of 3.2 and this lady is having AMH of 1.2. So this could be a scenario. As the age advances, we are going to have this more and more AFC and AMH discordance, because they will be having a short luteal phase. There will be a cycle of only 25 days, and their luteofollicle phase transition is going to start very early. And this is nothing but this slide, that whenever the lady is having advanced age or a very low ovarian reserve or a short menstrual cycle, what happens that as we have learned that before 3 days of the menses, the FSH will start, innate FSH will start rising, and that is what the innate FSH recruitment of the follicle. Now in this particular scenario, when we have a low ovarian reserve or advanced age with a short cycle, 7 days prior only the luteofollicular phase will start. So this girl will start having recruitment 7 days prior to the menses. Now she got her day 2 of the cycle, and as sir you are asking that on day 2 only you are seeing follicle which is 10 to 12 millimeter. So this follicle has recruited in her late luteal phase in the previous cycle. Now you are seeing her on day 1 or day 2 of the cycle, the follicle is already beyond 10 millimeter, like 12 millimeter and 14 millimeter. This follicle now is going to secrete estradiol. So if you do a estradiol level, many times it will be beyond 100. Now this estradiol will going to give rise to inhibin. This will be having a negative feedback mechanism on the pituitary to reduce FSH. Now in this particular scenario, you are only doing baseline FSH on day 2. Just imagine the FSH could be 5.2, but it will be falsely low. Because if you want to know a correct value of FSH, you have to do AMH, FSH, LH along with estradiol, or combining with sonography also. If she is not having a dominant follicle on day 2 or day 3 of the cycle, then whatever FSH you are seeing, that could be a correct value. But if she is having this follicle, your E2 is beyond 80 picogram or 100 picogram, means whatever FSH value you are seeing, that is falsely normal. And that is why we have to sensitize the patient. This will be because of your luteofollicular phase transition. And in this particular patient, your oocyte response or the ovarian response is going to suffer, and you may not get the follicle heard because asynchrony has already started. You are starting on day 2 or day 3 of the cycle, where nature has already started the recruitment 7 days prior to the menses. So this happens typically more than 35 years of age, and then we have to look for the follicle size. Then the question is whether this AMH and AFC is equivalent in control ovarian hyperstimulation. So they have done a very nice study that if you want to counsel a lady, let's say she has come to you and you have decided that you will go for IVF for this particular lady and her AMH is 2, then and you are doing a sonography and then you have AFC of certain amount, and now you have to counsel a lady in front of you what is the ovarian response you are looking at, whether she require 1 cycle or 2 cycles for that matter. So when they have done a retrospective analysis of Megaset and Merit trial, which was basically done for RFSH versus HPHMG, and they found that HPHMG is better than RFSH. They have taken AMH and AFC of both the population who have been into this study. In one population they have done agonist protocol, in one other population they have done antagonist protocol. In both the time, what we see that this triangle is AFC and these dots are AMH. The AMH is having linear correlation with the ovarian response prediction. So AMH is a better predictor of ovarian response to FSH than AFC in both the GnRH agonist and antagonist protocol. And then how we can practice in our clinical scenario. Let's say you have a lady of 1.2 AMH and you are able to see only 4 AFC. Don't stimulate at that particular time. Just call her every 8 days and see what is the follicle number you are seeing, because this value at this particular is telling only cohort of that particular cycle. Even the number is going to vary, and we have to tell them that these follicular waves which we have just learned in the first lecture, they are going to have one more FSH wave which are going to push the follicle. So instead of starting as a conventional protocol on day 2 or day 3 of the cycle, if the AMH is good but AFC which you are seeing on the sonography is very less, call the lady every 8 days. Now for 1 month you are monitor, but you are consistently seeing that her AFC is not going beyond, then you are convinced that whatever AMH you are looking for, this is the only AFC, now you can go for stimulation. But now it's 4, but when you are seeing her in late luteal and you are suddenly seeing 8 or 9 follicles, that is the actual time to start your ovarian stimulation. So many of the time when we take into consideration, it is AMH which we have to believe rather than AFC when in terms of ovarian response and counseling a client in front of us. This we have already discussed. About AMH, as we are discussing that AMH will be having different levels with different menstrual cycle, but in young ovary, whenever this AMH is going to have a variation, it is not going to vary much, it's not clinically significant. So you can do AMH at any day of the cycle. But in the aging ovary, this AMH will be having very very less variation. In young girl, it will be varying too much because it's a functional ovarian reserve what we are looking at, and the pool which is going to get recruited in that particular cycle is going to express the AMH. So if you calculate the AMH in the follicular phase, that will give you a true idea. But if you calculate at the luteal phase, because now the follicle is already ovulatory, you may look at the AMH which is little on the lower side compared to what we see in the follicular phase. So whenever we are collecting blood to measure the AMH, it has to be taken into gold top vacunator. And if you are outsourcing your AMH, then you have to centrifuge that sample. If you don't centrifuge, there could be a false increase in the AMH because during the transport, if it is taking longer time, and that is why increase in 20 hours is of 15%, but later 31% increase is noted along with long storage. So whenever you are outsourcing the sample of AMH, always centrifuge and then send the AMH for testing. About functional ovarian reserve and true ovarian reserve, this we already discussed that in younger age, the whole primordial pool is not getting expressed, and whatever the AMH secreting is only at that particular time. So this is a functional ovarian reserve. But in an older age, the primordial pool has already got depleted. So whatever we are seeing on the AFC in the ovary, it is correlating with the AMH. So in older age, we are having a true ovarian reserve rather than functional ovarian reserve. Can AMH predict the menopause? So sir has already discussed, they have done a study about predicting this menopause depending on AMH. So reduced AMH levels, they increase the risk of early age at menopause, but it's challenging to make a precise prediction of menopausal age solely based on the single AMH measurement. So what sir was telling is a trajectory of fall of the AMH and increase in the FSH. So both of these trajectory we have to take into consideration, then only we can say that this lady may have early menopause. Inhibin and follicle stimulating hormone, they won't be a better predictor of guiding towards the menopausal age. No additive effects in the prediction of POI compared to AMH. And low AMH, high FSH beyond 12. Maybe now she is going to premature ovarian insufficiency towards menopause, but we can't be certain that within 2 years or within 5 years she is going to have menopause. Then AMH also differs with lifestyle factor. So when they have done a systematic review of association between these lifestyle factors with circulating hormone of AMH, alcohol consumption, caffeine consumption, this doesn't have any correlation with AMH prediction. But BMI, smoking, OC pills use and exercise, these lifestyle factors definitely will have impact on the AMH level. High BMI, we are looking at low AMH level. Smoking also decreases your ovarian reserve faster. OC pills continuously, that also will have a negative impact on the AMH. Exercise, intense exercise which you are talking about, those who are into athletes and if you see, they will be having early menopause or premature ovarian insufficiency. That will decrease the AMH level of 0.4 nanogram per deciliter to 1.4 nanogram after 12 weeks of intensive exercise. And we have seen that in PCOS also, whenever we are asking, our main thing is to decrease the intensity of their ovarian reserve what they have. OC pills, average decrease of 1.97 nanogram ml after 9 weeks of OC pills, they have seen in this particular paper 20 to 30% reduction. But it is reversible, that also we have to assure, because you are doing when she is on OC pills. BMI is having inverse relation with AMH levels. Now, how this BMI or obesity will have impact on AMH levels? So whenever there is a obesity, they will be having a decrease FSH, decrease LH, increase E2 level, decrease luteal phase progesterone. These patients can be having low FSH and LH values also. These excessive insulin levels alter the granular cell receptivity and subsequently the AMH production. Also, the increased leptin production is associated with obesity and could directly suppress the AMH level. That is why impact of obesity on AMH catabolism excretion is also known, and this apoptotic effect will have a drastic decline in the follicle number, and that will give rise to low AMH in these particular patients. Now, another story when we talk about AMH, will be low in high BMI patient. One of the therapy which we advise to a morbid obese lady is to go for bariatric surgery. So this particular paper gives an idea that even we are advising somebody a bariatric surgery, we have to always counsel them that after bariatric surgery there is going to a fall in the AMH level. So this was a very nice study when they have done the serum AMH level after 1 year of bariatric surgery, and they have seen that their AMH is fall. This AMH decrease mechanism post-surgery is not known. This could be because of drastically undernourishment or the malnourishment which has been immediately in a metabolic way, which I am talking about. And leptin is one hormone which is also important for the follicle regularization. That also you are taking it drastically down. That will affect the reproductive function, which is tightly regulated by nutritional status. This decrease in AMH may be due to damage to the growing follicles heard, exposed to post-operative stress, which is a metabolic way also, and from the micronutrient deficiency point of view also. So you have to counsel the patient that whenever there is a drastic decline in the weight, so not about bariatric also, you may have a lady who is having 1.2 AMH but very obese. Now you have a dilemma that whether you have to ask that lady to go for intervention and treatment immediately or to ask her to go for weight loss, because that may affect her live birth rate. As such, BMI is not going to affect for the oocyte quality or embryo quality or euploidy. That has been well proven. But that may affect the live birth rate, because with this BMI, the chances of obstetric complication is going to be high, and that may impact on live birth rate, but not from the embryo quality point of view. Now you imagine that the lady is very obese and she is having 1.2 mH. Now with the therapy of weight loss what you are advising, within 1 month if she reduce lot of weight, let's say of 10 kg, you will see that she is having a drastic fall in AMH. And this is again going back to the stress, metabolic and catabolic stress that lady has undergone during that 1 month period. So you have to think wisely. You may ask that lady first to go for IVF, have the embryos which is secured, then to improve upon the live birth rate, she can go for weight reduction during that period and then go for embryo transfer after 5 to 6 months of achieving weight loss, rather than having weight loss before taking her for IVF stimulation. Anorexia or functional hypothalamic anorexia, this will be commonly by athletes, sportsmen, or beauty, because they are not having anything. They are like continuously either in the sports, so they will be having functional hypothalamic amenorrhea, or because of sudden weight loss they will be having very low FSH and LH, and because their GnRH pulse frequency has come down, and that will lead to a functional hypothalamic amenorrhea. So they will be having a fall in AMH and suppression of hypothalamus pituitary ovarian axis. What are the factors which affect the ovarian reserve? So this we already discussed, these were the factors. And one of the important factor what we take into consideration is the stress. So whether the perceived stress and markers of ovarian reserve among fertile population in this particular study was being published, they saw that antral follicle count, day 3 FSH, AMH, that all have drastically, FSH already drastically increased, or AMH drastically fall when they have a perceived scale of 4, and when it is going beyond that, they saw that this stress will definitely affect the AMH level. One of the main factor which will again affect in oncofertility, when the lady is undergoing chemotherapy, as we know it is a rapidly dividing cells, the chemotherapy act, and oocyte is also one of the rapidly acting cell, so that will definitely decrease the ovarian reserve. So what chemotherapy will affect in these particular patients, and what could be the markers where we can say this particular lady will be having a drastic fall? So they have confounder of ovarian reserve depletion in chemotherapy. The first is age. If she is young and very good ovarian reserve at that particular time, she may not have that depletion very fast. If you have done pre-treatment like giving agonist and then going for chemotherapy, that also will prevent her drastic decline in AMH. Monotherapy versus combined therapy. Obviously, monotherapy will be having lower fall of AMH compared to combined therapy. And individual susceptibility, that is very important, because some may have the impact in first cycle itself, but some may have impact after 3 to 4 cycles, even it's a monotherapy. So individual susceptibility is one of the important factor in prediction of decreasing the AMH in these oncology patients. Now, initially when I was talking about AMH in hypoc, like as I was telling that AMH could be low, AMH could be normal, AMH could be high in hypogonadotropic hypogonadism. So this is basically on the LH value at that particular time. If that lady is having a good LH at that particular time, this primordial pool will get expressed into preantral follicle with the theory we just explained. So some patients will be having low AMH where the true ovarian reserve is actually not getting expressed, and some could be having very high AMH. If she is not having, the lady who is having amenorrhea, since beginning only, initially she had some scanty menses and then she never had, and now she is coming to with hypogonadotropic hypogonadism, she will be typically having low FSH, low LH, low estradiol, low AMH level, and a hypoplastic uterus. So the length of the uterus will be less than 5 centimeter. And in these particular patients, first what you have to do is give sequential pills like 20 days of estradiol followed by 5 days of progesterone. That is going to improve the blood flow to that hypoplastic uterus. So till the time, even if she is planning a pregnancy after 10 years, you have to make her understand the hormonal ill effects, because she is having amenorrhea right now. And later on, when she actually planned to go for pregnancy, we have to build up her by giving sequential pills, which is going to be important for her metabolic health also. So we may have two scenarios with low FSH, LH, which is very, very low, and low FSH, low LH, but normal or high AMH. So what is important, if you see a hypoc lady, like we'll just give an example. This girl was having FSH and LH level which was less than 1. Now when we initially look at the ovary, it was only 3 to 4 follicles we were able to see in both the ovaries. As we counseled them that in these patients there is definitely no need of going for oocyte donation. What is needed for them, because their ovary has not expressed that FSH LH continuously, because there is no GnRH pulse frequency and they are fall short of this FSH LH exposure to the ovary, we have to give it continuously. Now you observe that you are giving gonadotropins continuously. After giving 10 to 12 doses of gonadotropin, now suddenly you see AFC which is either on either side of 12 tail or more than that. Because till this time the follicles were not having that much amount of gonadotropin exposure to grow this follicle from primordial to preantral follicle. Now at this particular time, you can take them for IUI also, or you can take them directly for IVF. You just have to tell them you have to be patient. We need not go for a donor cycle, but give this gonadotropin 150 IU continuously. In between, when you are calling them every 10 days, she will be having one dominant follicle. You may give ovulation injection for that and ask them to either intercourse or go for IUI. She may conceive in that way. Or if you are seeing a sudden increase in the follicle number, then you may counsel that lady that to go for IVF. But in IVF also, these patients are going to need longer duration of stimulation because this primordial pool was not previously get expressed. So previously you just give it for continuously for a month together, express that pool continuous, in a proper way, and then you give adequate stimulation as we are doing our conventional ovarian stimulation. Definitely in this patient, because the hypothalamus pituitary ovarian axis is not working, we need not go add antagonist in this particular patients because LH is going to be consistently low. Now, what is important in hypoc again to see whether it's of hypothalamus origin or pituitary origin. So you can do gonadotropin agonist stimulation test. You give a leupride of 2 ml, then half hourly you just check the FSH level. If there is increase, means the pituitary is still functional and it is a hypothalamus problem. Why it is important? Because suddenly the follicle number is growing and now you think that agonist is not going to work and we have to give HCG trigger. That is going to push that lady into OHSS. So this has to be done before taking this patient for IVF stimulation. Yes, we'll do in hyper, because if you have started thinking that she is having low AMH and you are giving continuously gonadotropin, suddenly you are seeing follicle number which is 20 which are growing. Now, if you give agonist trigger, you are in think that maybe it is not going to work because she is a hypoc, and if you give HCG trigger, she is going to have OHSS. But if you give this gas test previously and she is responding to agonist injection, then you can still give agonist as a trigger and prevent that up. But if it is the gas tag is negative, means the pituitary is not functioning, in that case we have to take a consent that she have, and then predicting OHSS, then after pickup you have to give her antagonist injection, cabergoline and letrozole to decrease the severity. Or obviously we are not going to do a fresh embryo transfer, so we can prevent. There will be definitely some mild OHSS or moderate is going to be there, but then we are certain and it's upfront counseling is there, so we are well prepared to manage that OHSS later. So this was the paper again supporting the same thing, that if we have a hypothalamic amenorrhea, we will be having a different kinds of AMH, and unless until we give gonadotropin, we really don't know what is the true ovarian reserve of that particular lady. So prolonged deficiency of GnRH or gonadotropins may result in reduced AMH concentration, in while cases AMH levels would not represent the follicular number. So don't go by AMH in patient with hypoc. It is depending on your gonadotropin exposure, and then that is going to have a better idea regarding the AFC. AMH in endometriosis, in this particular, we are just going to see only few slides because we have a different lecture on endometriosis altogether. As we know that AMH in endometriosis is going to fall after surgery. So whenever there is a ovarian endometrioma and you are counseling the lady to go for endometriotic surgery to improve upon the chance of pregnancy, we have to always counsel them that there will be a decrease in the AMH level. So initially, before this paper had come into 2022, there was a paper in 2021 which talked about don't do AMH level immediately after surgery, because from primordial pool to have this enteral follicle, it will take some time. At least you do it after 80 to 90 days where the actual pool is getting expressed, because if you do immediately after surgery, it's going to be low. But later on this paper came, whatever the surgery and whatever the minimal intervention you are doing, there will be a fall of AMH after surgery, and you have to take a prior consent before taking these patients to go for endometriotic surgery. So this was a review of 4,374 patients, significant lowering of AMH and no difference in short term, that is less than 1 month, to long term, that is more than 6 months level of AMH. So there is less evidence of AMH recovery post endometrioma surgery, and that is very important time when you are counseling the patient. Many times, you will be having a patient with endometrioma of bilateral endometrioma, maybe of 8 centimeter, 10 centimeter, and for your surprise, the AMH will be 4 or 5. And you are though counseling that after the surgery it's going to come down. After surgery, it may be 0.5. Now the lady is going to ask, doctor, what you have done after the surgery, because it is so much of fall of AMH after the surgery. So this was a proof of concept which was been published by Eunice et al. That whether this large endometrioma per se is having high increased level. So because you have a high endometrioma, this endometrioma will be having a high inflammation and a neoangiogenesis. The follicles are pushed towards the cortex at the periphery, and these follicles, because of this inflammation, are more from primordial is going to convert into antral, and this AMH is going to go into the blood circulation, which is in the vicinity at the cortex immediately. So high, like endometrioma cyst will be having falsely high AMH. So whenever we are going to counsel this patient who are having high AMH, you have to still give them a idea there could be a very drastic fall, because whatever AMH we are looking at could be a false high AMH because of the endometrioma which is existing over there. Then another reasons why there will be low AMH, the low AMH could be in patients of SLE. So these are the patients where they have autoimmune disorders like rheumatoid arthritis or juvenile idiopathic arthritis. We may see that twofold lower AMH in these particular patients. That won't be immediately at the onset, but later on we are going for therapy and over a period of time. Then autoimmune thyroid disorders, different prediction in adolescent doesn't affect, but they will have lower AMH in these particular ladies. A type 1 diabetes mellitus, again autoimmune disorder, will have earlier menopause, and that again hints towards twofold lower AMH in this particular patient. Then what is the option in this particular patient? Whenever you are seeing such client, make them aware either with their endometriosis or with autoimmune disorder that you will be having a drastic fall of AMH because of this problem, and the fertility preservation will be a better option for them rather than immediately planning for pregnancy. Then what we were debating on again about AMH and recurrent pregnancy losses and euploidy. So initially whatever paper has been published so far, like 2023, they are all saying that there is no relation of AMH with euploidy. So euploid embryo are associated with lower female age, higher AMH levels and higher quality of embryos. But whenever we have studied all this paper and gone through all this paper where they have correlated AMH with oocyte quality, AMH with euploidy rate or AMH with miscarriage rate, all of them have a conclusion that there is no association of low AMH with euploidy rate or miscarriage rate in euploid embryo transfer. AMH does not predictor of miscarriage in natural conception, neither in RPL. Best reproductive probability is age, because if age is on the higher side, definitely if the AMH is on the lowest, then that is a marker of aneuploidy, means you can predict that more amount of aneuploidy can be there. Screening for AMH in all women with RPL is not supported by current evidence. But as sir was discussed that the recently whatever paper we are seeing, there could be a patients who are having low AMH could be having recurrent pregnancy losses, but we need more data, because there will be always a subgroup that in particular patients only this possibility is on the higher side, but in others we not. And we have to ask the history, if there is a genetic reason of having low AMH, whether it is because of autoimmune problem, and with all the considering background factors, we have to counsel that lady that whether we are looking at euploidy or aneuploidy or high miscarriage rate only because of low AMH reason. Then whether doing a salpingectomy either in ectopic pregnancy or when you are encountering pyosalpings or tubal pathology, whether the salpingectomy will affect the AMH. So we know that when we have a oophorectomy, there is a drastic decline in the AMH, but with the study which has been published in 2020, what they have found that salpingectomy did more harm to ovarian reserve than proximal tubal occlusion in terms of ovarian reserve. So whenever you are doing salpingectomy, you are actually cutting the ovarian circulation towards the ovary, and that will decrease the AMH, not immediately, but over a period of 2 years, in future there will be a decrease in the AMH level. So they have found that the AFSH is going on the higher side, and AMH and AFC lowering in patients who are undergoing salpingectomy in this particular paper. And I'm not going to details of that. They have just given an idea that instead of when you do it minimalistically, first address to the mesosalpinx, vasopressin, and minimal near the tubal level only, you cut the tube, and at the proximal tube you just occlude rather than taking more chunk from the mesosalpinx, and that will prevent a drastic fall of AMH after salpingectomy. Thank you so much for the patient hearing.